Hello, everyone, and welcome to the Safer Air Project and IDFA's webinar. We know that living with an immunodeficiency means thinking twice about taking most things for granted, like going to work, attending appointments, or even catching up with friends indoors. That's where we're hosting this webinar on making indoor air safer for everyone, which puts a spotlight on something we don't always see, but something we always need. I would like to start tonight's webinar by acknowledging the traditional custodians on the lands on which we meet today and to pay my respects to their elders past and present. I would also like to extend that respect to any Aboriginal or Torres Strait Islander people here today. Just an overview of the webinar. We're just going to welcome all of our speakers and our audience tonight. We're going to talk about IDFA, about the Safer Air Project. We're going to look at an understanding of the role of indoor air quality on health. And then we're going to investigate practical daily interventions for improved air. And we're going to have one of our lovely IDFA members share their insights. So welcome to our IDFA members, friends and community. And for those who don't know, we are a patient organisation who has been around for 20 years. And our key priorities are around raising education and awareness of immunodeficiency, providing care and support by building community, and running advocacy programs to drive change and lead to improvements for those living with an immunodeficiency. So I would now like to introduce our first speakers. We have with us tonight Plum Stone, who is the CEO and founder of the Safer Air Project, and Amy Lewis, who is a co-founder, director, and the marketing and communications manager for the Safer Air Project. So just a little bit of background into our first two speakers. Plum has worked in health policy and public affairs for the last 20 years, with experience in the UK Parliament, international public affairs agencies, and in-house for patient advocacy organisations. Plum wrote her undergraduate dissertation on learning the lessons of pandemics of the past to prepare for pandemics of the future, and has a master's in public health and nutrition. Amy is a designer and advocate with more than 25 years' experience in marketing and visual communication. She's worked across branding, campaigns, print and digital projects with clients ranging from boutique startups to government and corporates. She also ran a design studio for 10 years, delivering thoughtful design solutions with a strong emphasis on story and a curiosity. I would now like to hand over to Plum and Amy for their presentation.
Thank you, Carolyn, and thank you very much for having us and for working with us on this exciting collaboration. As you mentioned, my background is in health policy and patient advocacy, and I've really just always been interested in how policy can either solve or exacerbate health problems and how it shapes who gets to stay healthy and who doesn't. So at the start of the pandemic, my professional experience collided with my personal life. I was living in the UK with my young family, and we all became really unwell. 10 days after our symptoms began, my 3.5-year-old daughter was hospitalized with a prolonged status epilepticus seizure and was hospitalized. And while she thankfully recovered, I went on to develop long COVID, which still affects me today. But my family's risk didn't end with that infection. In fact, that was sort of really the beginning. My husband is severely immunocompromised and needs to have a transplant as a result of that condition. And my son also has an autoinflammatory condition. And really, like so many others here, we live with this constant risk of navigating schools and workplaces and healthcare settings where exposure to airborne pathogens in shared indoor spaces can have serious consequences for our health. And that experience really left me with the question that I couldn't ignore. I kept having these sleepless nights sort of thinking, well, how do we solve this problem? What are the policy solutions to the challenges that we now face when the air that we share indoors is a problem everywhere? and really recognizing that many viruses are airborne and primarily transmitted indoors, especially in poorly ventilated spaces, was a turning point for me. Airborne pathogens like flu, COVID, RSV, etc., they all disproportionately harm people living with chronic health conditions or immunodeficiencies, and yet our buildings, our policies, they largely ignore this reality. And I just couldn't let the idea that we should all be able to breathe safely indoors. I couldn't put it back in the box that it had come out of, and just, we needed to do something about it. And so that's why I founded the Safer Air Project. We're a health promotion charity advocating for indoor air quality to be recognized as a accessibility and inclusion issue. Our work is evidence-based, community-led, and informed by lived experience. And that's why collaborations with organizations like IDFA are so important to us. We have been, ever since we were founded 18 months ago, we've been leading national conversations on indoor air quality and really trying to get it seen in health conversations, in disability conversations, in workplace health and safety conversations, in education, because we share air in all of these spaces. So our vision as an organization is simple. It's to create a world where everyone can breathe safely indoors, ensuring healthy and inclusive environments for all. And we're advocating for this recognition of indoor air quality as a critical accessibility and inclusion issue for all of us, but especially for people living with chronic health conditions. Because ultimately the burden for staying safe shouldn't rest on the person living with an immunodeficiency. It shouldn't rest on the child. The burden shouldn't be an individual burden. It's something that we all share. And shared air, we can make indoor air safer for everyone. We just need to make it a priority and do something. So a bit about the rest of the webinar. I'll give you a bit more kind of background into Safer Air Project and what we're doing. Amy's going to run you through the basics of indoor air quality and how people can understand the tools and the technologies that we have to help us understand, is the air in this space safe? What can I do to make it safe? And then we'll hear from Diane Edwards, a registered nurse, who will also talk to us from the clinical perspective, and Jo Reynolds, who's an IDFA member, will provide her insights as well. So without further ado, I'll ask Amy to start our presentation. Okay, hope everybody can see that. Okay, so as I mentioned, at the Safer Air Project, we're working really hard to have indoor air quality recognized as an accessibility issue. We want, and it's a totally new way of thinking about the air that we share indoors, but obviously it's something that I'm sure many people on this call tonight will have had experience of, thinking over the last 5 to 6 years. How do we access this activity safely? So a major focus for us has been the development of our community support program, and that's obviously why we're here tonight. We've been partnering with IDFA, with Emerge Australia, and with Cystic Fibrosis together to help raise awareness both within organizations and also within their communities about the role of indoor air quality in health, and most importantly in indoor air quality and preventative health. So we have been working through the development of resources, and we will share those a bit later. They're really intended to help empower individuals to understand what changes they can make, but also we've produced advocacy tools as well for you to be able to take to school and take to the workplace in order to help you have those conversations. And we're actively planning to expand this program to more patient organizations this year. So hopefully we can reach more people and help more high-risk community members. And of course, the thing that really struck me when we were sort of founding Safer Air Project was there was from the very outset of the pandemic, there was this discussion around vulnerable people being a very small minority of a population, and of course that's not the case. According to the Australian Bureau of Statistics, 1 in 2 Australians lives with at least one chronic health condition. Women are more likely to have one chronic health condition than men. And these chronic health conditions, beyond people living with immunodeficiencies, may include things like asthma, diabetes, cancer, heart disease, and so many more. And then add to the numbers, 4.7 million children, 16% of the population being over the age of 65, and 3.8% of the population being Aboriginal and Torres Strait Islander peoples. The picture becomes very clear. Actually, this isn't a small minority of the population. The they that was referred to is in fact actually all of us. And so we're trying to change that as well, and to bring visibility to those of us living with high risk health conditions, so that we're not just seen as being a small niche group, but actually being part of every school, every workplace, every community. So in addition to our community support program, we've also been working on our invisible inclusion program, which this slide shows us. This is about sort of transitioning our community support program into the workplace, so that we can help workplaces understand actually that invisible inclusion, invisible disability inclusion is also part of workplace diversity, equity and inclusion programs, and should be included as well. We know that safer air reduces sick days, it improves productivity, and it supports inclusive workforce participation. So it's good for health, and it's also good for business, and it's also good for all of us, so that we can safely access the workplace. And then finally, our third kind of pillar of work is our advocacy. We're really working to drive policy change. In November last year, we launched our first advocacy report, Safer Shared Air, a critical accessibility and inclusion issue. And you can see Amy and I here pictured very proudly clutching copies of our report, with the former Assistant Minister for Health, Jed Carney, and Dr. Ananda Raja. And we're very excited that Dr. Ananda Raja has been returned to Parliament as a senator, and as a we're also excited to let you know that she will be co-chairing a new parliamentary Friends of Safer Indoor Air. But that is we're yet to announce that, so that's a special announcement just for this webinar. In our report, we really identified there are 4 priority settings, as I've sort of already alluded to. Education, every child has a right to access a safe learning environment. It's time we started thinking about the air that our children share in the classrooms, healthcare environments, because we have a Charter of Healthcare Rights and all patients should be able to access healthcare safely. Disability, aged care and residential care. Again, these environments must offer protection for residents from the risk of exposure to airborne pathogens and other airborne pollutants, and workplaces. So that's a really just kind of quick run through of the 3 areas that we're working in. And I'll hand over to Amy, who's going to just talk you through the basics of indoor air quality.
Thanks, Plum. So what is indoor air quality, and why is it important for people with immunodeficiencies? So some of this content might be familiar for some of you, but I just wanted to give an overview for anybody that might be new to the topic. We drink around 2 to 3 litres of water every day, and water can spread contaminants that can cause illness. So we filter and treat it. And there are rules that govern how it's handled. We breathe around 11,000 litres of air every day. And air can also spread things that can make us sick. And given that we spend 90% of our time inside, indoor air is particularly important to consider. And while there are standards for outdoor air, we don't currently have indoor air quality standards, and that's actually a large part of what we're working towards at the Safer Air project. Since 2020, there's been a lot of focus on making surfaces and hands clean, but we know that many viruses actually spread more often through the air that we breathe. Things like colds, flu, RSV, COVID, whooping cough, and even measles and chickenpox are classified as airborne viruses. So this means that our indoor air quality, the air that we share indoors, is really important to consider if you're wanting to reduce your exposure to or risk of these viruses. So it's also important to note that there are other airborne contaminants that can adversely impact health, like mold, other pathogens, and VOCs. So when we're in poorly ventilated spaces, we breathe in air that other people have exhaled. And the poorer the ventilation and the more crowded the space, the greater the amount of shared air, along with an increased risk of illness if someone who is present is unwell. And although we'd hope that people who are unwell would stay home, you can be infectious with things like COVID and chickenpox before you're even aware that you're unwell. And perhaps we'd also like some strategies about how to avoid illness if someone in our home is actually happens to be unwell. So what is ventilation? Oh, sorry. So someone who is unwell breathes virus particles out. Their breath moves around the room and is inhaled by others. Your immune system might fight the illness off, or you might become unwell. And so normally we can't see air, but I think this is a great video to just sort of show how breath can behave when we've exhaled, and it can actually hang in the air like smoke. So ventilation is basically taking stale, possibly rebreathed air out of a space and replacing it with clean, healthy air. This can be done naturally, so for example, with doors or windows, or mechanically with HVAC or some types of air conditioning systems, types that bring in air from outside. And it's just worth noting that some types of air conditioners actually just recirculate the existing air that's in a space. They don't all bring in air from outside. How can we tell if ventilation is bad? So one way is by monitoring the carbon dioxide or the CO2 in a space. So when we exhale, we breathe out CO2. And if a room is poorly ventilated, the CO2 accumulates and levels will increase. So this means that we can use CO2 as a guide for rebreathed air and an indicator of poor ventilation in an indoor space. Studies show that carbon dioxide itself can also have direct health impacts and can cause symptoms like fatigue, headaches, dizziness, and others. Studies link high CO2 with decreased productivity and poor cognition and decision making. So these are all fantastic reasons why we should be thinking about the ventilation in our indoor spaces. Well, what do you do if you don't have access to a CO2 monitor? So it's a little bit trickier to assess the ventilation, but if the air feels stuffy, if there are lingering odors, or if people are getting drowsy like all of the asleep people in this photo, they can be indicators that the ventilation in a space isn't great. You might also notice some condensation on windows, or that the space feels warm and stale even though people are moving in and out of that space. What are the solutions to improving indoor air quality? So there's a lot of interesting and sometimes complicated science around the solutions, but it can be simplified to keep an eye on the air quality and act to improve it when it's poor. Those actions can be as simple as opening a door or a window. Crossflow is actually really important here. So basically making sure that openings are on opposing sides of a room, and this actually helps air move through a space. And those openings don't always need to be large, which is really good news at this time of year, especially if you're in Melbourne like I am, and it's a little bit chilly outside. So it's actually interesting that if it's warm inside and cooler outside, or vice versa, the difference in temperature actually helps with that air exchange, and you don't have to have windows open quite so wide. If it's a still day, you can use fans to help encourage air movement. If a space isn't well ventilated and then it's not easy to change, so there's no doors or windows to open, and upgrading HVAC is not an option, portable air filters like HEPAs are a great option. So they improve indoor air quality by filtering out viruses, allergens, and other harmful particles from the air that we breathe. They're a practical and comparatively low-cost way to reduce airborne infection risks indoors, especially in shared spaces. I prepared this animation for a talk that I gave at my daughter's school, and I'm not 100% sure about the evidence base that they will filter out smells, but the kids did seem to enjoy that aspect. And it's probably worth pointing out actually as well that HEPA filters won't lower CO2 levels while they're filtering out all of those other particles from the air. Masks are another simple way and effective way that you can reduce the spread of airborne illnesses. Wearing a mask helps protect the wearer and other people nearby by reducing the number of virus particles that are released into shared indoor spaces, and also by filtering the air that the wearer is breathing in. There are many types of masks available offering different levels of protection, but a well-fitted and if possible fit-tested N95 mask offers really great protection. Masks with head loops as opposed to ear loops are also preferable, so as shown in the photo here. And I also just wanted to add quickly that one of the reasons that indoor air quality standards are so important is that the onus can't always be on the person who is at risk to wear a mask. And in fact, it's not always possible. A family member of mine was hospitalised before Christmas and was unable to wear a mask because of their breathing difficulties. So we were really relying on the indoor air quality of that hospital and also, people in their vicinity wearing masks to protect them from further illness. And I just wanted to include this to show that small actions can have really large impacts. So this is a CO2 graph from a classroom from a few years ago, and it shows really clearly how simple actions can really directly influence the ventilation and air quality in a space. So there was no fancy sort of HVAC systems and nothing automatic happening with windows opening on their own or anything like that. Just somebody had happened to leave a door open at one point in the day, and you can see that the CO2 drops right off, and that means that the air quality in that room had improved, which is fantastic. So if we understand that viruses like cold, flu, RSV, COVID, chickenpox and others can spread through the air, and that improving indoor air quality can reduce the risk of somebody becoming unwell with these viruses, then it's really logical to then consider that indoor air quality is an accessibility and inclusion issue. And we're really hoping that by raising awareness of this, we can share an opportunity to protect your health and well-being. And I'll just throw back to Plum.
I think to Carolyn.
Oh, sorry.
Fabulous. Thank you, Plum and Amy, for your presentation and for starting the Safer Air Project. And to all of our members and other guests who are listening out there today, we're absolutely delighted to have been one of the first patient organisations to have been able to collaborate with Plum and Amy. And we'll talk a little bit later in the webinar about the resources that we've jointly developed, but we will be working alongside Plum and Amy to continue to advocate on this important issue, which was in fact brought to our attention when we first started hosting in-person events post-COVID. Many of our members were concerned about safer air and air quality in the venues which we were using. So I will just head back to my presentation now to introduce our next speaker. Okay, so our next speaker tonight is Di Edwards. Di is a long-time member of IDFA and brings deep expertise and will be sharing information on practical daily interventions for improved air. By way of introduction, Di is a nurse practitioner working with children, teens and adults with allergy and clinical immunology at the South Australian Flinders Medical Centre, where Di has worked for the last 20 years. Di has extensive experience and interest in the areas of teens and young persons care, primary immunodeficiency, drug allergy, anaphylaxis management, and consumer-focused healthcare. Di has participated in the development of hospital and community health management programs and is a member of the IDFA healthcare professional panel and has worked in many settings with IDFA. So I would like to now welcome Di Edwards and ask her to do her presentation.
For inviting me today, Carolyn. And I'd also like to acknowledge Plum and Amy for their work in this space, which is really, really interesting. So, okay. As Plum and Amy have alluded to, we live mostly indoors, even in Australia, which is quite something, isn't it? We live a lot of our time in our homes, and homes can be houses, units, apartments, or caravans. Okay. Workplaces such as offices, warehouses, workshops, retail, and hospitality. That's just to name a few. We also live mostly in healthcare venues, and we might be at the GP in the waiting rooms, we might be in the hospitals in the medical day unit, or sitting on a ward with 4 other people in the bay. Also, a lot of people would be visiting physio and allied health clinics. Same again, you've got even smaller waiting rooms sharing with some poor lady who's over in the corner coughing her lungs up, which tends to make everybody rather twitchy. Also counting indoors as transportation in the car. So if you are traveling an hour to work each day and an hour back, you are spending 2 hours of your indoor life in your own car. We also include bus and trains. Also, once again, moving around our cities and our regional areas in public transport, but not just public transport for work, but also for going to get shopping. And especially if particular people can't drive, then they are subject to using public transport when there is no other choice available to them. And of course, aeroplanes, the flying petri dish. It is just a tin can with some HEPA filters. So let's face it. What I'd like to discuss today is what is the problem with our indoor air and how do we deal with it? So various factors can be moved into 4 different groups. Volatile agents, also known as VOCs, allergens, irritants, and infectives. A lot of this work has also been done by the WHO as well and the Victorian government. There is some really interesting stuff coming out of the EPA in the US before, not so sure after. But VOCs, or volatile organic compounds, probably the main thing that you would come across that this would go bing, bing, bing would be the new car smell. So when you get a new car and you go, oh, what a lovely new car smell, that's the plastics degrading. It's also in painted surfaces, has been used for a long time in paint. It's used in carpets, fiberboards, furnitures, air fresheners, pen markers, and yes, those craft materials while you're sitting there having your infusions. And when you fill up at the petrol station as well. Short of sticking you in a bubble, this is really hard to navigate, okay? Nobody needs to go live in a bubble, by the way. There are ways. Allergens can be categorized into house dust mites. These are aeroallergen. These are the things that are in our air that we breathe in. Sorry, guys. Thank you. We have house dust mites, pollens, molds, and pet dander. So house dust mites look like this under a microscope. Yes, they're gross and they're revolting, but they are part of nature's cleanup crew. They clean up after us, and without them, we would be this high in our own dead skin cells, which is just gross. So one of the things I'd like to highlight, I don't know if you can see my cursor here on the screen. Are you able to see that? Okay, so this is a perfect case of know your poison, know your problem and find a solution. Now, these little critters have a hard shell, okay, that is clear. Okay, this is how they look under a different microscope. Under here is nice and clear. Okay, they have these little calipers here on the end of their hooks so they can hook onto your fabrics and things. They also eat your dead human skin cells. And the bit that we actually have a problem with is actually their feces, which they do 80 times a day. This is where you go ploop, ploop. Okay, so revolting, right? So one of the key ways is know your poison. They drink through their shell, which means they like humidity. So open a window, get rid of the humidity. They will hang on if you just wash, hot wash. You'll kill them, they'll let go. Okay, there's lots of different ways we can work within this space. Now also pollens, oh, I've got them back front. Okay, so these pollens here are the common ones in Australia, though there is variation first and foremost due to your climate zone. And secondly, these are changing because of climate change and droughts and rain. So the perennial ryegrass is the one that gets up in the air. Probably the October long weekend is the first one to kick off the pollen party. So a lot of these pollens travel hundreds of kilometres in the wind, and that's what happened in the Melbourne thunderstorm asthma attack years ago. And that was people with not really bad asthma. They were just people with really twitchy airways, so to speak, where the thunderstorm picked up the ryegrass in country Victoria, took it to Melbourne and went bang. Okay, so these pollens can then find our way into our houses, particularly if you've got roof spaces such as tiles. They'll find their way into your homes. Okay, we'll go into that in a minute. Of course, mold is always a big one on everybody's lips these days. There's a good way to get rid of mold, and that's stick a mask on, stick some rubber gloves on, and bleach the bejesus out of it. And that will get rid of it. But also noticing what's on the back of your curtains. If the humidity is quite high, it's going to be on the inside of your curtains. And every time your dog goes to the window to chase the postie out the front, it's going to be liberating those mold spores. So once again, if you don't like humidity, open a window. Of course, it might be cold. All right, cat dander is a particular interesting one. Not many people are allergic to dogs, which is really reassuring, I think. But cats are a different matter. Now, that's not to say people aren't allergic to dogs. It can be an important allergy to have if, for instance, one of your family one of your family members needs a guide dog, for instance. That's going to be a serious problem. But cats are insidious. They poor cats. I'm insulting them. So sorry. But they leave their dander around, and they leave it for years behind. You have a house with cats in them, you could scrape down the walls and find cat dander up to 7 years later. There was a baby study done a few years ago in terms of it wasn't a big study, but the researchers actually measured the amount of cat dander in a school classroom. And even though there was no cats there was enough for 4 cats to be living there full time. How did it get there? On the kids' clothes. So it was being brought in and then dropped. Let's go home. Let's bring some more in. Okay. So irritants is another category that is quite often confused with allergy. Okay. This is where strong smell irritate the airways, which might cause swelling either of the throat or in the sinuses to try and either block it from your lungs or shed it out. These in particular are perfumes. This is where people might say, oh, I'm allergic to perfume, especially when someone gets in the lift. No, it's irritant, okay, which is good because you can actually do something about that as well as allergy. But the treatment is different. Cleaning agents in particular, the fumes that come off those cleaning agents can also be VOCs, but can just plain old be irritating. Flowers. If you have sensitive airways, don't have flowers in the house. they shed, they collect dust. It just adds to that soup in the indoor air structure. Bushfire smoke is certainly consideration for us Australians, and an increasing consideration overseas as well. So here's us saying to all the punters that, you want to improve your air quality, open a window or open a door. However, there are certain days where that is not a good idea. Amy and Plum discussed infectives, and in discussion, I think all of the people from IDFA as consumers would be an excellent resource in infections. You guys have been following this topic so intensely for 5 years now. I think all of our audience here could probably teach the experts quite a lot. So you keep your finger on the pulse. You've learnt how to navigate relevant information and not off the garden path information. You've probably learnt to become amateur researchers, recognizing good research versus bad research. And I'm sure Joe could speak to that in a bit. So there's various groups of infectives. Now, the ones I want to hone in on here is our favorite, the viruses, of course, because we've just been living viruses, haven't we? Back in the good old days of, Spanish flu or polio epidemics, public health measures were the only things we had. And that was masks, social distancing, stay home if you're unwell, so that you're not contributing to infecting other people in the public with respiratory illnesses. We have moved up to vaccinations, and that was why what moved us into the next phase of the pandemic. And that was because science finally got there and got a vaccination over the line. In fact, we had several. Vaccinations are crucial to the fighting off of viruses. We have antivirals, but only for some things. And some of them are really dangerous to have. So if you're really, really sick, of course, you're going to want them. But if you're not really, really sick, they can do a bit of damage. So vaccination prevention is very important. On a side note on vaccination, to those of you listeners out there, is that the shingles vaccination, Shingrix, has just been made available for people with immune deficiency over the age of 18 and is now covered by the PBS. And I highly recommend everybody goes to their GP or their specialist and obtains that vaccine. It's excellent to have a non-live shingles vaccine because people with immune deficiency cannot have live vaccines. So this is just amazing. There is now a vaccine for RSV, although it's still sitting at $300 an injection, but that's easily accessible now. TGA has signed off on it, and it is a very effective vaccine. And of course, we have vaccines for COVID-19. And if you want to know what is the most effective COVID-19 vaccine at the moment, go to the ATAGI website, ATAGI, and that will give you all the information you need. And that is currently managed by Australian GPs, not the specialists. Same with viruses. Bacteria are great with public health measures. There are plenty of bacteria out there that we do not have any treatments for. And I could spend an entire week on this one slide, but I won't. It is important, however, to get the correct antibiotics. When you have immune deficiency, it is very nice to have a swab done. I have noticed with the patients I work with is that when GPs look at a range of possibilities, yes, you have an upper respiratory tract infection, it's likely to respond to amoxicillin. Here's your amoxicillin. However, immune deficiency people or people with immune deficiency sometimes pick up weird things. And so it's nice to actually start your antibiotics, but then getting a swab done is also ideal. How do we avoid all that? Some long-term protection is great. Getting some chest physio done if you are someone with poor lung function, just so that the chest physio and someone who specializes in chests, who can then work to open up those bottom of your lungs, so that when you do get a bacteria or a viral illness, you can then expectorate from nice down and low and shift it. Keep your vaccines up to date, take your medicines, and open a window. I do say quite regularly breathing is a good idea. So what do we do about it? Okay, so I've plonked these all together rather than trying to attach them to different things, because a lot of things do make a difference. One of the really interesting things about Australian housing, older housing, not necessarily newer housing, is that you'll find the front door and the back door line up. And that's very specific in Queensland. And that is so when you open the front door, you get beautiful ventilation to the back of the house through the back door. So identify where your ins and outs are. Amy alluded to this before. It comes in one way, goes out the other way. So try and open up some opposites. If you were going to clean the house, use a face mask that is appropriate. Okay, for cleaning, you are stirring things up. Okay, dust mites, for instance, will in your house stay to the carpet. They won't go above your knee unless you stir them up. If you vacuum, you will stir them up. If you mop, you will stir them up. If you sweep, you'll stir them up. Okay, if you sit on the floor, you're getting in dust mite land. So just be mindful that you're stirring all these things back up into the air that you're breathing. A HEPA filter is a specific filter that is designed to do microfilter of things that are in the carpets that don't kick out the back of the vacuum. HEPA filters are used extensively in industry and now in a lot of healthcare settings. In fact, it has done for a lot of years in healthcare settings, on aeroplanes, all sorts of places. And I see they're popping up in movie theatres and all sorts of places since COVID. Where they're used in operating theatres, which I did my spell in for quite some years, is that the total air of each operating theatre is completely removed 20 times an hour. The complete cubic airspace in an operating theatre to keep the germs down in an operating theatre is huge undertaking. And you just think we just buy things like scalpels and stuff, but no, we build these fancy filters. It is to keep the bugs down with open wounds. Okay, it's probably the best air you'll ever breathe is in an operating theatre, but it's very difficult to do in your own home. So keeping the humidity down in your house, just try using not necessarily the air conditioning as a removing things, but try, if you're in the bedroom and you're noticing you're getting quite that moldy, damp smell, or what have you, put your aircon on dry for a while and just see if you can dry some of that humidity out. It'll kill the dust mites, kill the mold, and dry out your clothes as well. Hot washing your bed linen above 55 degrees will kill the house dust mites. It'll also get rid of any sort of skin bacterium or anything like that, staphs that you might be brewing on that wet towel that's been hanging around for a week, or the bed linen that's had the cat on it as well. And don't have stuff all over the bed. Your favourite cushions, okay, it's not Better Homes and Gardens. Get rid of all the cushions and all the teddy bears and all the frivolous things off the bed, okay? If your kid has teddy bears that cannot be hot washed, fair enough. Stick it out in the sun, nice hot sun, or stick it in the freezer. You can snap dry your dust mites, but it won't remove the rubbish that they've left behind. Now, if it's a high pollen count day, don't open a window. Now, this is where we get complicated, isn't it? But by doing those things on other days does enhance the fact that you can get away with it on other days. Using car vents on recycle on those days, but then open up the doors and windows on a nice sunny day. Don't hang your washing outside. You might have just killed the dust mites, but don't let the pollen attach to it. Okay, so sometimes you're going to need a dryer, clothes dryer, for those sorts of things. But if it's a nice sunny day and it's not a pollen count day, go for it. Remove smelly things. No more flowers in the house. No potpourri. Remove smelly things. Remove those things hanging, the pine trees from your window in the car. It's full of VOCs. We don't know all the answers in science, and asking these questions and having these forums will give us opportunities to investigate things further. There is poor scientific evidence for house dust mite covers. You might have come across these. They're things that you encase your mattress and your quilt cover with. 50% of research trials have demonstrated they're brilliant. They reduce the dust mite load. The other half of the research studies have said they're terrible because it doesn't change symptoms. What's your measure? Indoor plants are a great reservoir for dust and mold. But contrary to what we believe, indoor plants do not contribute towards cleaner air in the house. They're not filters. They're just lovely and calming to look at. The irony is when we get rid of our indoor plants, people put plastic ones in, which are just full of VOCs. So put some nice pictures up. Home purifiers are really interesting because in terms of research, I think COVID-19 has created a really interesting research brief for us to look into those things. As I said, it takes 20 times total air change per minute in an operating theatre. So a piddly little air filter in your bedroom is not going to do a great deal. So, but there is some really interesting work in that space, and I think stay tuned on it. So, but in saying that, I'm not going to buy one. And just a quick thing to finish on is that somebody was talking about fit testing about masks. I think it was you, Amy. For those people who don't understand out there, that is when, as health professionals, we have one of those masks that makes you bleed and then tie it up here and tie it around there. And the fit testing comes when they stick sensors inside the mask to see where the leaks are. So it's interesting to bear in mind the level of different masks that we have available in the community, but to get fit tested if you work in healthcare or something like that, great opportunity. But otherwise, you just have to work out where your holes are. So I'm happy to answer any questions via email if you want me to. And thank you, Carolyn.
Thank you, Di, for that really practical presentation. There's many takeaways for all of our members who are watching tonight. And as Di mentioned, if you do have any questions, feel free to email them through to us at info@idfa.org.au. It is now my pleasure to introduce our final speaker for this evening. And I would like to introduce IDFA member Jo Reynolds. Jo has been a patient member of IDFA and lives with a complex web of comorbidities of her own, and is also parent to children with rare disease and complex health needs. One who also has CVID and another who has inherited a rare disease from Jo's husband. Jo spends too much time, advocating within the health and education systems, and a lot of time coaching other patients or parents on how to navigate these systems. Clean air and respiratory infection control measures are a particular concern to Jo, both as a patient and as a parent. So I'd now like to hand over to Jo to share her insights and experiences.
Thanks, Carolyn. I'm really grateful for the chance to speak tonight. I'm a member of IDFA because of my own and my child's immune deficiency, but the topic of indoor and outdoor air safety is particularly important to me because in addition to my immune deficiency, I also have a paralysed right diaphragm, which has reduced my lung capacity by about 40%. I have myasthenia gravis, which can cause neuromuscular breathing failure, and lupus. Which is a really unfortunate constellation of issues to have together. With careful management, I managed to remain pretty stable, but my ability to continue to breathe easy, the topic of tonight's webinar, is precarious. As you can imagine, I care pretty deeply about air quality and safety. As an immune deficient patient, I'm also acutely aware that I am at risk of remaining infectious for longer than other people. In fact, for nearly 2 years now, I've been intermittently testing positive for RSV and flu B on rat tests whenever I have symptoms, but I'm PCR negative, and this is something of a conundrum. With that in mind, I'm not only concerned for my own and my child's safety, but I would also be horrified if I infected someone else with whatever it is that I've been percolating for the last 2 years. I wanted to start, so with all that in mind, I wanted to start by talking a bit about my experiences of indoor air quality since the COVID pandemic started. Due to time constraints, I'm going to focus mainly on medical settings and mostly on infection control. But my personal ability to breathe is also extremely dependent on managing things like pollution, chemicals, perfumes, pollens, and mold, which was covered by Di. There's a saying that I really like: when you know better, you do better. And we learned a great deal about airborne infection control in 2020, especially here in Melbourne, where our healthcare workers fought really hard to have adequate airborne protections to keep themselves safe and to keep our hospitals open and functioning. Naively, I thought that having learned how well respiratory protections worked, that they would become a permanent part of our healthcare settings, at the very least in the high risk areas like day oncology and respiratory wards. How wrong I was. In order to access immunotherapies, I've been a regular patient in day oncology at multiple different hospitals through Melbourne over the last 5 years. During the peak of our COVID restrictions, day oncology felt like a pretty safe place to visit. Air filters were running, there were no guests, it was compulsory that everyone wear an N95, and rules were really strict about not coming for treatment if you were unwell, or if you needed treatment despite being unwell, your treatment was given in an isolation room. So the actual main open day oncology rooms felt safe. And then slowly that changed, and I noticed multiple issues after this change. Firstly, a decline in the quality of care that I and my child were receiving. After the removal of airborne protections, it seemed like staff were off sick more often. There was more staff sniffling next to me, which is pretty frightening, and more mistakes were made. It's not clear to me whether those mistakes were made due to short staffing from people being off sick or whether people were feeling subpar. There was a dramatic increase of coughing in day oncology. It went from a really quiet ward to a really loud one, which I found distressing to hear, and it led me to feel really unsafe to remove my respirator, even briefly, to eat or drink, which I had done previously. Once the rules were removed, I also often found staff were either unwilling to wear a mask, or they were willing if I asked them, but they were confused and lackadaisical in their approach, for example, wearing only a baggy blue or exposing their nose. I really believe that all important safety measures need to be compulsory, taught, and maintained by hospital policy. If a safety measure is not required by policy, clearly some staff will feel that it must not be that important, and they can then resent patients who self-advocate. And they may see patients who ask for extra safety measures as being difficult or neurotic. No patient is expected to have to individually ask every staff member to wash their hands or use gloves before performing tasks. Sometimes a staff member might forget, but gently handling the occasional omission is quite different to having to advocate with every single person at every single interaction, like we now do for masking. Also, unlike hand washing, with airborne safety measures, if you have to ask each staff member individually, then they've already exposed you and themselves to any risk that might be present before the conversation is had, which is ridiculous. This issue really negatively impacts my family being safe, and we spend a lot of time in hospital, and thus being able to feel trusting in healthcare settings. Failure to keep patients safe at a policy level fundamentally threatens vulnerable patients' relationship with the healthcare system. I'm currently not having the IVIG that I'm supposed to have because I no longer felt safe in my hospital. In addition to infection control concerns, I also tend to have be quite reactive to a wide array of airborne irritants like perfumes, pollens, etc. Very recently, my child's hospital has moved the paediatric ward to the other end of the hospital to what was a different ward. And the new rooms inexplicably have carpet, dodgy old carpet, and I can't actually be in those hospital rooms without wearing my ventilator, not a CPAP machine, an actual ventilator. I use a non-invasive ventilator about 12 hours a day. Now, I'm particularly vulnerable, and because my respiratory function is quite easily diminished, I'm a bit of a canary in the coal mine, but nobody should be exposed to whatever it is that's in that carpet in that hospital ward, let alone sick children. I find it really disturbing. And another healthcare irritant issue I regularly have had is going into pharmacies, and I've had to flee without paying and without taking whatever I came to purchase because they're burning, they've got those oil burners right next to the cash register, and I actually stop being able to breathe and have to get outside and can't go. And I've tried arguing with pharmacy staff a number of times that people with asthma And people with other respiratory problems and allergies come to pharmacies to buy their crucial medications to help them breathe, and that we should have the right to clean and safe air in pharmacies. And they just stare at me blankly or say nobody else has complained. I once had a woman standing behind me say, "Oh, I don't like it either," when I was told that nobody else had complained. But it's not just about infection control. It is also those other issues that Di spoke about don't only apply in our homes, they also apply in medical settings as well. And it's vulnerable people that will be most impacted in those medical settings. Having talked about what I've noticed with air quality over the last 5 years, what does my family do to stay safe was the next question I was asked to talk about. Firstly, over the last 5 years, we've had really good success at avoiding respiratory infections in general, not just COVID. And we've had 100% success at preventing onward transmission of COVID within our home once an infection was identified or even suspected. One of my kids currently has flu B and nobody else has caught it. Pre-pandemic, pre-putting the measures that we now use in place, if that one same child caught the flu, everybody in the family caught the flu. They're a super spreader. And so that's a big change for us. Coming back to now that we know better, we do better. So what do? My husband, my immune deficient child, and I all wear masks at all times in public indoor places. We never eat or drink indoors in public. And we are especially careful in small spaces with poor ventilation. So toilets, bathrooms, medical offices, pathology collections, cars and buses. We actually don't ride in buses because they have appalling air circulation. We have multiple air filters in the home and they are each sized for the space that they run in, and we maintain them carefully. We replace the filters, we clean the filters, that sort of thing. We make careful use of evacuator fans and the opening and closing of doors to control the airflow throughout the house, either to direct it into certain places or out of certain places, particularly when someone's sick. We use an Aranet CO2 sensor. We have an air filter in our hospital go trolley that's always packed and ready to go, along with the double adapters, the extension cords, and all the other hospital day stuff that we're probably all familiar with as immune deficient patients. We make very generous use of COVID, flu, and RSV rats and PCR tests. Anytime someone has symptoms, they're tested. And so that we identify and isolate people as quickly as possible. We isolate sick family members, and sick people remain isolated until they're testing negative. And even once they're negative, we tend to keep the person who was sick wearing a mask inside the house for another 24 hours or so after the first negative test. It's a pretty short list, but it's worked really well for us. Socially, it does mean that we tend to have people come we'd be more likely to have people come to our house than to meet people in cafes or restaurants or indoor eating places, or even other people's homes that might not have the same air quality control measures that we've put in place. And finally, my hopes for the future. My hope for the future is that the onus for prevention of for the provision of safer air is accepted as an institutional and government-based responsibility and not dependent on individuals. Individuals have a shared responsibility to contribute, but we need to be supported at a structural level to do this. This means air quality legislation. It means permanent rather than fluctuating air quality and infection control enforcement in medical settings. It means air purifiers are well maintained and always turned on in all the places that we already have them. Like, I know in Melbourne, so many hospitals, clinics and schools have filters, and almost everywhere I go, they're now turned off, and it makes me want to cry. It means compulsory N95 use by all people in all medical settings. And I would also love to see air quality readouts in public places to enable people to make personalised decisions about their safety levels. This is especially in hospitals, medical facilities, aged care and school. So that's kind of all that I had to say. I really wanted to thank Caroline and the Foundation for allowing me to speak today, and to all of you for listening to all of that, and I hope it was helpful. And I really wanted to thank the other speakers, Plum and Amy and Di, for the information that you've provided and the work that you all do on a daily basis to try and keep all of us safer. Thanks very much.
Thank you, Jo. That was absolutely fantastic. So hopefully to our audience from tonight, hopefully you've been given three very different but also interlinked perspectives about safer air. So first of all, we heard from Plum and Amy about the Safer Air project and the importance of that and their motivations for starting that. Then Di, with her medical and healthcare background, provided us with some really practical tips. And then Jo, as a member of IDFA, living with immune deficiency and also other vulnerable members in her family, has really shown the importance of advocating for yourself around this particular issue and what that looks like in different healthcare settings and in fact in different settings that we enter every day. And perhaps for others who don't have immune deficiency or chronic conditions, they may not think about that. So it's really important for us as an organisation and as individuals to raise that awareness and to advocate for those things that are important to us. So before we go any further, I would really just like to thank all of our speakers and to say we'd really look forward to working with this group around progressing the goals and the advocacy around safer air within all of our environments. I'm now going to hand back to Plum and Amy. Just before I do so, I will share a slide. They are going to talk about some of the amazing resources that are available.
Thanks, Carolyn, and especially thanks to Jo for sharing your story. I'm sure I can speak for Amy when I say that both of us are living in exactly the same situation and using exactly the same measures that you are using. It is really hard, and I want to acknowledge, how hard it is living like that. And that's really why we created the Safer Air Project, is so that people who are in exactly this situation have the resources that they need. Because I personally don't believe that individual patients should be having to take this on a one-by-one basis. There is a power imbalance that exists in a clinical patient relationship, and it's really hard. So hopefully some of the resources that we have created here, will be able to help. So we've developed a range of articles and fact sheets, and I can't see because my glasses are not working. My contact lenses are getting dry, and I can't. So I've made it bigger. Okay. So we've got a CO2 monitoring guide, which will help just with the purchasing, and I also have an ARANET. This is what Jo mentioned. I'm not doing too badly. 712. The air filter purchasing guide, absolutely, it will talk you through how to correctly size an air purifier for the space. We don't need to be at 20 air changes per hour in our homes. 6 air changes per hour is really good. And when you've got someone infectious in the house, bumping that up to 12 air changes an hour is really helpful. I know that Amy's persuading her family members that they could do with another one to get to that level. And then we've got these other, employee toolkits, how to have the conversation with work, a healthcare toolkit, how to have that conversation with yet another healthcare worker about, can they keep you safe by wearing a mask, and a school advocacy toolkit, because schools are really, one of the places where many infections are coming from, unfortunately, and we really should be doing better to protect our children. So I believe the QR code should work to take you to the page. And we welcome your feedback.
I would also now like to thank our sponsors. So CSL Behring are one of our long-term sponsors who provide a level of support to allow us to host these webinars. As you know, we do have a regular webinar series, and we will be bringing you another webinar in August, September. If you have any further questions for us, you can email us at info@idfa.org.au. Otherwise, please keep an eye on your inbox for a copy of the recording and our Q&As and future webinars. And before I go, I would again like to thank both of our speakers and for our audience for attending tonight, and have a lovely evening. Thank you.
Thank you very much for having us.
Thank you.